Dear students, today we'll be learning about the injuries of the brachial plexus. We have already discussed about the brachial plexus, its formation and location. So before going in details, I'll quickly recap the basic concepts and then we'll proceed with ongoing things. So now let's start with, so there we are looking at the roots, the nerve roots, and who are contributing the ventral rami of my C5, C6, C7, C8 and T1. They are contributing in making the brachial plexus. We have already discussed about the ventral rami of C5 and C6, they join, C7 stays alone, and C8 and T1 they join, and when they join they are forming what? Trunks, and these trunks are, you can see them with this green, and they are labeled as superior, middle and inferior. After that, each trunk divides. Divides how? Divides into anterior and posterior. So each division, you can see it's going, the red color indicates the anterior division, and then the blue color indicates the posterior division. So now we are clear. My superior trunk divides into anterior and posterior, middle, anterior and posterior, inferior, anterior and posterior. Now see what happens with the anterior divisions. Now the anterior division of my superior and middle, they join, and they are making what? They are giving us chords, and there you can see a chord which has been visible to you. I am not naming it here at the moment. Now I am saying this is a lateral cord. Why this is a lateral cord? Because in this location we have an artery, and that artery is called as axillary artery. So this cord is related laterally, is placed laterally to my axillary artery. And then what we can see, the anterior division of my inferior trunk, it goes and it continues as a cord which is indicated with a green color, and that will be medial to my axillary artery, so we'll be calling it medial cord. Now what we are left with, we are left with all these posterior divisions. Let's look what happened next. Now all these posterior divisions, they are going to be one, and this is the fate of my posterior divisions. They join, and they are responsible to supply the extensors of my arm and forearm through the different nerves. There are so many, but worth mentioning are axillary and the radial. Let's see what happens with the lateral, medial and vice versa. So now the lateral and the medial cords, what they do, they are sharing, and they are giving something in common, and that becomes, so there is a medial root and there is a lateral root, and they are joining to give us nerves. So what are the nerves? So let's see, lateral cord becomes my musculocutaneous nerve, and this musculocutaneous nerve is responsible primarily to supply the flexors of my arm. And what are these muscles? These muscles are coracobrachialis, biceps brachii and brachialis muscle. And then after supplying these muscles, it becomes sensory, and it continues further. Then my medial cord, it continues, and what nerves is coming from there? We are getting in a big way ulnar nerve. We have so many other names, but I'm just mentioning the big names because we have already learned those concepts. So this becomes ulnar nerve. And what is the job of the ulnar nerve? Ulnar nerve has no contribution in my arm. It has only two muscles to supply in my forearm, but its main job is to control the intrinsic muscles of my hand. So primarily this serve, the main purpose of the ulnar nerve is through supply the muscles. Which muscles? The intrinsic muscles of my hand. And what is this union? The lateral root and medial root, they are joining, and there is a nerve coming out of this union, and that is known as the median nerve. And this median nerve, primarily it is for the flexors of my forearm, and then it has a little bit to do with the thenar eminence muscles who control my thumb. These are also the intrinsic muscles, but these are very few in number. Are we good so far? So this was a quick recap. And as I already said, the posterior cord gives us, along with other branches, but worth mentioning are axillary and radial. Now, before we go, there is something important which should be worth mentioning for this quick review. C5, C6 and C7 roots, they join to become one, and they are giving us lateral thoracic nerve, the long thoracic nerve, and this long thoracic nerve is primarily controlling my serratus anterior muscle, is again another important muscle, and we have talked about this muscle before. So now let's look at a complete brachial plexus and what we were seeing in the previous animated version, how these different things were forming, and you can identify. It's your job to label it and just see it, how good you are, and you can see everything well placed. So now this is the label version, and just match. This is an activity for you guys, so how you can understand. Everything is numbered and labeled. So now, as today we'll be talking about injuries which are occurring to brachial plexus. If we look at the location of the brachial plexus, it's located in a very strategic area. On one side there is a mobile neck, on the other side a very mobile upper limb. So it is in between these two. So there are fair enough chances of traction type of injuries. Avulsions can occur within the course of different nerves and the brachial plexus. To understand the injuries of brachial plexus, we categorize it under three headings. The first heading, the main plexus injuries, and we categorize it as injuries occurring to the upper part of the plexus and injuries occurring to the lower part of the plexus. Then we have a regional classification. We all know the brachial plexus has is located in different regions that extends from the roots to the nerves. So if the injury occurs at the root level, at the division level, at the cord level, at the trunk level, so what are the consequences? And then there are peripheral nerves, and they have their individual injuries, and those muscles who are innervated by those nerves, they will be affected in that situation. So now let's classify it, as I said already. So upper and lower part of the plexus, that we'll be doing right now today, and then we'll be talking about the different regions of the main plexus that I said, roots, trunks, division, cords, and the terminal nerves. I'll not be talking today. That will be a separate lecture. Now, this is worth reading. The regional distribution of the components of brachial plexus is important clinically, as different lesions and different type of pathology can affect the different parts of the brachial plexus dependent on the region where they are located, giving rise to different clinical syndromes. So patient will not come and tell you, I have an injury in my median nerve, I have an injury in my ulnar nerve. That person will show it to you. My hand has gone like this, my fingers are not moving this way, I'm unable to perform this action. So from this you can take the lead, and then you go and then you look into that, which part is being affected and what's going on, and that there we need to be acting, and we cannot rest and relax. If there is an injury, we have to do something so that there should not be a permanent deformity. If we can intervene early, we may have better results, but it depends on, it's not your prerogative at the year 1 level. Just you need to know, you need to understand what are the basic presentations, the treatment and the other options. They are beyond the level of this class, and we are not discussing them today. We are only looking at it, the different presentations. So now, the injury which occurs to the upper part of my plexus, it's famous with the name of abducene palsy. So what happens? There are so many mechanisms. Let me show you one. Somebody is falling. So what you can see here, there is a stretch occurring between his neck, head and the shoulder, and due to that an injury may happen. And the outcome, this person, let's look into this picture of the brachial plexus, and there you can see the clavicle which has been cut, and there you can see the sternocleidomastoid muscle, and behind we can see the spleniae, and in between the spleniae my brachial plexus is emerging from C5, 6, 7, 8 and T1, and you can see it's going its course. This part above to the clavicle we call it supraclavicular part, and below to the clavicle we call it infraclavicular part. Very easily you can see the axillary artery. On the basis of that we were naming the cords lateral and medial and posterior, and then you can see the axillary vein and its different tributaries has been shown, and some branches of axillary artery are visible, and then you can see the intercostal muscles and the upper ribs that has been shown up on this image. So now the injury, as we said, the upper part. So where is the upper part? Most likely this area. So see what happens. So there, this focus on this green oval. So that's the area. If it damages, then and that there is a location of a point, we call it Erb's point. And if the injury occurring to the upper part of my plexus, it's famous with the name of Erb-Duchenne palsy. And this injury can be occurring due to some accident in an adult life, or it could occur, mostly it's involving during the childbirth. How and what happened, let's look into these details. But the outcome is, if somebody has this Erb-Duchenne, this is how the presentation of this hand of the affected side of the plexus, and this will be the most common presentation. Guys, when we talk of presentation, it's variable. How much is the damage, what went wrong? So we have to be like, you should not be looking at it, what I'm presenting here, as a classic bookish picture, but there is always a cusp, something less, something more. So now, and this presentation is a very classical name, Vader tip hand. And what happened, that we need to know. You as a student of anatomy today, you should be knowing that the injury is occurring where, at C5 and C6, and this result in what? Loss of my shoulder abduction. So deltoid is gone, so means axillary nerve has something wrong. Elbow flexion is lost. The reason behind is my bicep brachii and brachialis muscles are affected. It means my musculocutaneous nerve has a problem. And then further, the resulting deformity upper limb, referred as the Vater tip, we have talked about it. And then we'll be looking further points, and then I'll be talking about why the elbow is not flexing, why the hand is in abductor format, the next slide. And first see that when a child, during a childbirth, we all gone through this process. Some of us have undergone through a cesarean section, but majority has born normally. And look at it, sometime look at this shoulder got stuck, and we call it shoulder dystocia. And there is the pubic symphysis of the mother, and because of that it was obstructed, and now somebody was trying to pull it out, and when enough force is applied, you can see a traumatic situation occurring at the upper part of my plexus, and this will lead to Erb-Duchenne. And look, this child will present like that. As we have said, the arm is medially rotated, elbow is extended, forearm is pronated, wrist is flexed. Why this is happening? Try to understand all those muscles who are responsible. Why this is adducted? Means my abductors has a problem. Why this is medially rotated? Means my lateral rotator, they lost their function, so they cannot bring a good lateral rotation, so only medial rotators are working. Why the elbow is extended? Because the flexors are affected. And who are the flexor of my elbow? We know them already, my bicep brachii and brachialis. Forearm is pronated, so means I already mentioned the bicep brachii, and the prime function of my bicep brachii is supination. So supination is not working, so the forearm always stay in a pronated format. So my biceps is gone, and supinator is not that strong to bring about a good supination, and the pronators are well effective, both those who are responsible for pronation. Who are they? They are pronator teres and quadratus, they are effective. So this baby cannot bring about supination. And then the wrist is flexed, so you can understand there is some more injury. So let's look at it. So just look at it. I'm showing you the plexus, different formats. So the upper plexus injury, we have talked about it, and this is how this child, look at his hand. Guys, this injury can be variable, but this is a commonest presentation. And now let's explain it with the reasons. What you need to know: adduction of the arm. If you see this image, the arm was adducted. Why? Because there was a paralysis of my deltoid, and we all know deltoid is the chief, one of the major muscles who bring abduction at my shoulder joint, along with other stakeholders. Medial rotation of the arm. So arm is in medially rotated format because the paralysis has occurred to my suprainfraspinatus and the teres minor, and they are the lateral rotators, and supraspinatus also assisting my deltoid. So the arm will be staying in medially rotated format. It will not be in going into the laterally rotated format because these muscles are not able to produce their action, and one of their action is lateral rotation. Guys, when we talk of the action of muscles, there are some major actions and there are some other actions. So we have to keep in mind everything, and we should correlate all the factors. Extension of the elbow, we have already talked about it. The reason for this extended elbow, because flexors are not working. Pronation of the forearm, because supinator are not affected, and you know the bicep brachii is the chief supinator of my proximal and distal radioulnar joints. And then we might have a loss of sensation, but that is minimal. It can be there, it cannot be there. And there will be involvement at the C6 spinal nerve. So these are the factors which we should be good at it, and you are expected to understand why this arm is adducted, why it is medially rotated, why extension is at the elbow, and why not flexion is not possible. So why these actions are permanent and they are not counteracted, because the injured part of the plexus was responsible to control those muscles who are bringing the abduction, who are bringing the lateral rotation, who are bringing the flexion, who are bringing the supination. So they are not working, and that's why this person who is affected cannot be able to produce those actions. And you can see only this format: adducted, medially rotated, extension, extended, and pronated arm by the body, and that explains abduction. This is the classic, and you are expected to be engaged with this and with the reasons what happens. And now there I am showing you all the list of the muscles, which nerve supplies them, what are the root values, and what are the action which they are normally doing. Now because of this injury to my upper plexus, so we will not see these actions. So this has all been explained here. So the muscle who are affected, and once they are, their control is not there, so we are missing these type of actions. So these actions are missing, and that explains everything which we need to understand. Now, if we have injury to the lower plexus, that is given the name of Klumpke's. And what happens? Look at this guy, he is falling down, and now he was able to hold, he was falling from a tree, he was to hold a branch of that tree. Oh, he survived. Yes, he survived, but at the cost of something. Look at it, this red arrow indicates where the whole body weight, gravity, everything, he got a full stretch in this area. Guys, this is not the only mechanism. There are so many mechanisms, but for your simplicity, for your understanding, I'm not bringing up everything. And now the same picture, we have already talked about it, only we need to look at it. There is the lower plexus, lower part of my brachial plexus. So that was affected. And this will be the presentation of this person, and this will be a claw hand. Are we good so far? And these are the reasons. So now C8 and T1 are primarily affected, and we all know the ulnar nerve, and then the intrinsic muscle, precision muscle of the hand, they are going in deformity, and that will result in a clawing of my hand. And then we have other thing, and if along with that, guys, this is stretch, if the sympathetic chain is also involved, then we'll have a very important thing, and that is Horner syndrome. Let's look into this coming part of this my presentation. Look at this nice looking beautiful girl. Look at one side of her face and look at the other side of the face. There is some problem. Look at this hand, look at the claw. This was the normal side, and this is the side where the problem has occurred. So the lower plexus injury, and look at it, the whole presentation. So now we have name for that. So loss of sensation along the medial border, we have the intrinsic ulnar claw, and then we might have an Horner syndrome, and that is how it is being like how we characterize that. We may find partial ptosis. So look at compare the two eyes. So ptosis is what, the opening. So the partial ptosis, meiosis, and hydrosis, and ophthalmos. So you can see the difference due to the involvement of the sympathetic fibers, and that we need to understand. And now this is the same, has been explained here, the claw hand, and that is due to what? Paralysis of flexors of the wrist and fingers. So they are not working, and all the intrinsic muscles, they are not doing their job. And then loss of sensation, and then Horner syndrome, we have talked about it just now. Now again, these are the muscles who are affected because this injury. These are their nerves who are controlling them. These are their root values, and now these are the actions which have not been occurring, and due to that these affected people will be showing a classic Klumpke's paralysis type of pattern due to the lower plexus injuries. I hope we are clear. You need to be connected to this concept in primarily way, that what are the muscles, what are the nerve roots who are affected, and due to that what are the functions which are not possible. Now we'll be talking about the regional injuries. So now there I'm showing you this person. You can see this redness. This is a severe pain. Pain cannot show with this red color, just to show it to you that how this person, he's in severe pain. If you focus on his face, I have just cut it because of the identity reason. Otherwise, he is in severe pain. And see what happens? The injury is occurring at the root level, and that is located in my paravertebral region. And if you look at this brachial plexus, this is where the roots are. So injury is occurring somewhere here in my plexus, and look at it, the side view of this person, and look at it, these vertebral bodies. So they are causing a compression. There are various reasons. Look, there are degenerative changes. There are other issues, disc herniation. So now this nerve root is being compressed, and as a result, we have a classic presentation. Look at this X-ray. You can see because we all know these nerves are emerging through intervertebral foramina, and once there is something wrong with the disc, so now this nerve is being compressed at the point of its origin. And look at it, the nerve which has been shown involved. There is another X-ray of the neck. So the condition comes called cervical spondylosis. And what are the characteristic features of how we can define it? It's a journal term for age-related wear and tear affecting the spinal disc in our neck. And as the disc dehydrates and shrinks, so now we can find all these signs. The nerve root is being compressed, and as a result, patient is severely affected. He might present with paresthesia. Paresthesia is what? A numbness, some tingling sensation, something weird occurring, and this pain is radiate towards the neck, shoulder, and the limb. It is different from my angina pain, which is due to the heart. And later, if this problem pursue, and you don't go for any intervention, you leave the patient alone, it might result into the atrophy and weakness of the affected muscle, because the first indication for a nerve injury is always a pain, loss of sensation, and if you don't pay attention, then it will lead to a permanent deformity. So there are so many ways of treatment. As I said earlier, we are not going to talk about the treatment details, or not about the investigation. Now the second phase, look at it. What you are looking in this image, you are looking at the scalenii muscle, and they are being highlighted. So what is this level? This is the level where my trunks are. And what trunks we have just discussed today? We talked about superior, middle, and inferior trunk in between the interscalenii muscle, and we know there is an anterior, middle, and posterior scalenii muscle, and my brachial plexus, the trunks are emerging in between these muscles. So once there is an hypertrophy, so that they are compressed. What is the location? This red dotted line indicates the location of my trunk, and at that level, if my brachial plexus is being compressed, we can have a scalenii syndrome, and that will result in same effects. So now these muscles, they undergo hypertrophy and they cause compression, and then that will result into pain, loss of sensation, and all that. Now let's look at costoclavicular syndrome, how it is coming. So when we have involvement of my divisions, and what divisions we will be talking, we have discussed today, we have talked about anterior divisions and posterior division. If the effect is at that level, if injury is at that level, and what could be the causes, what are the situations. So now we can have costoclavicular syndrome. So now the clavicle through costoclavicular space, so space between the clavicle and the first rib, you remember we talk about it. So after fracture of clavicle, when after fracture, when there is a union, sometimes it's not a complete, some malunion, so there might be some extra callus which is formed that may cause compression on that, and that result into this classic costoclavicular compression syndrome, and that will result into same paresthesia, loss of sensation, and then if it's not handled in time, then there is a complete loss of function, and all those things may come in picture. I'm using the word may come. It depends upon how severe is the problem. And now the last one, the injuries which are occurring to the cords. And now what happens? Look at it. What is the situation? Hyperabduction. What is hyperabduction? For example, you are sleeping on your hand. Where is the region? This is the region of my cords. And now prolonged shoulder hyperabduction occurs during your sleep. If we are habituated sleeping on our hand, we might develop this pain if it's too much. Or let's say you think you start painting the roof of your room, and then it's not your normal job. So think of when you're painting the roof, so your hand will undergo hyperabducted format, and it might result, and then there will be compression of the neurovascular structure. You can see that they are compressed because of, there is hyper movement, hyperabduction. It's above your shoulder, and if it stays for longer period, the people might be affected. So this is all about the regional injuries, and the remaining part will be about the peripheral nerve injuries that we'll be talking during, inshallah, our clinical anatomy session. So here I have a little bit test on you, your knowledge check, and I'm showing you some of the things which we have discussed and some of the things which we will be discussing. So let's try to figure out, see what is there, what is this presentation we have just discussed today. So this is my upper plexus injury, and it's famous with the name of Vater's tip of Duchenne palsy. Now going to the next, this is if median nerve is involved, the hand might go in this format. This is called hand of benediction, and this is ulnar claw. We are familiarized with that. Ulnar nerve injury, lower plexus injury are associated with this situation. In Klumpke's paralysis, we have discussed this a lot about this today, and we'll be learning in more details. And then the last one, that is the wrist drop, and there is the involvement of my radial nerve. Are we good so far? Thank you very much. You are highly recommended. Please, when you visit your labs, try to identify all these things and pay attention. Nerves, their injuries, their effects are one of the very integral part of understanding the concepts. What concepts? The functionality of the muscle. And if you understand the nerves, the attachment of the muscle, I'm again saying not origin insertion, attachment of the muscles and the function performed by this muscle, these muscles, then you are able to get highest marks in your upcoming exam, and I can wish you luck. Thank you very much.